right, now I'm going to talk about, in this video, bipolar disorders and schizophrenia. So starting with bipolar disorders. Bipolar is another disorder that, same with OCD, I think that it sort of has entered the popular lexicon in a way that's a bit inaccurate. People might refer to themselves jokingly as bipolar, just indicating that they're moody or have mood swings in a way that doesn't rise to the level of clinical. Bipolar disorder is actually a pretty difficult illness to deal with and a pretty difficult illness to treat. So, bipolar disorders are imagined to be a class of disorders that live somewhere in between your psychotic disorders and your depressive disorders because it has elements of both. So, bipolar doesn't have psychoses that typically rise to the level of schizophrenia, but it does involve some sort of paranoid or delusional beliefs that accompany those sort of high manic episodes. But there is that key uh, unstable mood, those mood swings that characterize bipolar disorders. So, bipolar is going to be an illness in which the individual will have some highs and some lows. We refer to the highs as manic states, being in a state of mania, and then the lows are basically just a depression that share a lot of the same features with a major depressive disorder. There's various subtypes of bipolar. Certainly the most common is going to be bipolar 1 and bipolar 2, but there are others. But this does largely have disorders that are characterized by an unstable mood. So bipolar 1 disorder, this is going to be an illness characterized by the presence of manic episodes. So these are going to be your highs. So these are going to be periods of abnormally and persistently elevated mood that last for at least a week, during which the individual experiences a grandiose, inflated sense of self-esteem, as well as a heightened sense of energy, diminished need for sleep, and a lot of talkativeness and extroversion. So during these manic episodes, a fair amount of the time, the individual with bipolar is actually having a great time. That sort of classic high of feeling creatively juiced and feeling great about yourself. This is definitely possibly going to be present during the manic episode. Now, this might make it hard for the individual to seek treatment because they might see these manic episodes as important for their creativity. And these might be periods in which they are able to get a lot done and have really high hopes and dreams for what they can accomplish. The problem comes in because during these manic episodes, people may engage in behaviors that are unhealthy. They might go on long binges, they might alienate other people. There can be a lot of damaging behavior that takes place during manic episodes, maybe compulsive shopping. So, despite the fact that the sufferer may have a subjectively positive experience during the manic episodes, one is that they're not always going to be pleasant for the person. Sometimes they are going to involve some unpleasant or unhealthy behaviors. And additionally, once the person is out of the manic state, they might not feel so great about what they did. Additional features that might be present during this manic state: racing thoughts, distractibility, goal-oriented activities, and excessive involvement in risky activities. So again, this is a really interesting psychological experience because some things are maybe ostensibly positive. The idea that you're very motivated and you feel great about yourself. These are the kinds of things that in smaller doses are actually good for an individual to experience. It's that it rises to such a high that people might engage in dangerous or unhealthy behavior. For an individual to be diagnosed with bipolar 1, often individuals are going to have a major depressive episode that follows the mania, but not always. It just might be that the mania reduces to a slightly more even keel and you get to a low point, but it doesn't actually reach all the criteria for an actual depressive episode. But there will be some features of a major depressive episode, although you don't have to meet all of the same criteria for MDD to meet the criteria for bipolar 1. Bipolar 2 disorder is a sort of a pared down, not as serious version of a bipolar disorder. So it sort of shares the features of the mood swings of bipolar 1, but the highs aren't necessarily quite as high. Most of the time, there will be somewhat of a manic episode, and the symptoms might be the same as a manic episode that an individual with bipolar 1 has, but it might shake out slightly differently than the manic episodes from a bipolar 1 disorder. Now, bipolar 2 disorder is also going to be associated with a major depressive episode. So, in the case of bipolar 2, to meet the diagnostic criteria, you do need to have met all of the criteria for MDD as well. So, bipolar 2 disorder definitely has more of those stable and persistent lows that an individual with bipolar 1 might not necessarily experience. Additionally, bipolar 2 is not going to cause as much distress and impairment as bipolar 1. Again, manic episodes are there, but they might not be quite as high and thus as damaging as the manic episodes from bipolar 1. And then, again, the depressive episode will be there. But individuals with bipolar 2 tend to see sort of less extreme outcomes and don't need to have quite such severe treatment to help them. So, in terms of the checklist of bipolar 1 versus bipolar 2, again, the diagnostic criteria are similar but just slightly different. So, for example, the manic episode of bipolar 1 is going to last for a week plus, versus the hypomanic episode that is slightly shorter in duration. So, bipolar 1 is a slightly more severe sort of way that bipolar can manifest. Slight differences in the diagnostic criteria have to do with the official diagnosis of depression and the persistence of the manic episodes. Bipolar is actually, in terms of illnesses that have been researched as having a strong genetic heritability component, bipolar actually rates as the strongest, very close with schizophrenia. Both schizophrenia and bipolar have about 80% genetic predisposition, leading to the susceptibility for having or developing bipolar. And interestingly, bipolar does have some features that are maybe akin to some psychosis. Again, the level of psychosis doesn't rise to the level that schizophrenia does, but they do share some features. And likely it is the case that something in the genetic makeup that leads someone to be vulnerable to schizophrenia and bipolar, there's likely an overlap in that genetic origin. Other factors that can put someone at risk, because despite the fact that heritability is 80%, there's still that 20% room for external factors. So, for example, cognitive factors that can lead someone to be more at risk for developing bipolar include goal striving, perfectionism, self criticism, and autonomy or an independent streak. Additionally, there's some interesting cultural factors that lead some individuals to be at heightened risk. Bipolar is actually more common in high income than low income countries. So, for example, the rates of bipolar in the United States might be higher than in certain developing countries. So, cultural experiences, for some reason, can lead to a heightened risk factor. And there's also room for social or environmental factors, so recent life events and social support. If you don't have as much social support when you're going through your various mood swings and your manic episodes, the idea is that you're going to possibly alienate people in your life, and that's going to make recovery a lot more difficult. So, not having a good amount of social support can lead to a heightened risk factor for developing bipolar if you have the genetic predisposition, and it leads to more difficult prognosis and a longer time to recovery. Additionally, stressful factors often do precipitate the first manic episode and can often precipitate those shifting mood states. There are a lot of comorbidities that go along with the diagnosis of bipolar. One is the likelihood of attempting or completing suicide. Individuals with bipolar have a much greater lifetime suicide risk than those who are from the general population. So, this is definitely going to be an illness that often will necessitate a lot of intervention to help people because they are at high risk for developing suicidal ideation. Additionally, there's quite a bit of comorbidity with alcohol use. Again, this is typically going to go hand in hand with the manic states that you might see someone engage in risky substance abuse disorders. So, you do see quite a bit of comorbidity with alcohol abuse. Additionally, you see a lot of comorbidity with anxiety. As high as 3/4 of individuals with bipolar are going to have a comorbid anxiety disorder. And additionally, you see a lot of individuals have, again, a substance related disorder. So, all of these factors just heighten the severity of the experience of bipolar. It is definitely up there with schizophrenia in terms of difficult disorders to treat. It is also additionally potentially difficult to treat because, again, it might be the case that individuals in the manic stage feel like they are achieving a lot or getting a lot done in those stages, and that might make it hard for someone to want to seek treatment. Now, moving on to schizophrenia. The word schizophrenia breaks down in the two subwords of schizo meaning split and phrenia meaning mind. So basically, this is going to be your most severe psychosis based disorder, which means that the individual suffering from schizophrenia is going to have a break from reality. They're going to experience delusions and hallucinations and basically be somewhat divorced from an objective reality, and they're going to have their own experiences of reality that other people don't share. So the typical symptoms classically associated with schizophrenia of delusions and hallucinations certainly are often present, but that's not the only diagnostic criteria for schizophrenia. There are also associated symptoms such as flattened affect or other eccentric or bizarre behavior, as well as cognitive factors like disorganized thinking, inability to speak coherently, your quote unquote word salad. So this is definitely a quite severe disorder. In breaking down the symptoms associated with schizophrenia, we term some symptoms as positive symptoms and negative symptoms. Now, don't be fooled that a positive symptom means a good thing. This actually refers to an additive feeling or behavior. So, a symptom that adds something into someone's experience versus a negative system, which is the taking away of something that should be present. So, again, positive and negative is not being good or bad. Most of these symptoms are bad. A positive symptom is, again, to be the presence of something that shouldn't be there, and a negative symptom is going to be the absence of something that should be there. Again, this does not mean the good versus the bad symptoms. Again, it's what things are there that shouldn't be versus which symptoms, which behaviors and experiences are not there that should be. So, for example, your positive symptoms, again, presence of problematic symptoms, these are going to incorporate your hallucinations, delusions, disorganized thought and speech, and other bizarre, inappropriate emotional and behavioral experiences. Negative symptoms, on the other hand, these are going to be, for example, your flattened affect, the social withdrawal and reduced social interaction, difficulty understanding emotions, anhedonia. I've used this word before when talking about depression. This is the inability to experience pleasure when encountering things that used to bring you joy. So, anhedonia is definitely a feature that can go along with schizophrenia. Difficulty speaking, and in some certain severe cases, catatonia, moving less, being more lethargic, up to and including potential catatonic states whereby an individual is basically motionless and silent. So, breaking down some of the most classic symptoms of schizophrenia, again, disturbed perceptions are going to be a major component of this illness. So, individuals with schizophrenia often experience hallucinations. So, these are going to be perceptual experiences that feel real to the person going through them that other people can't see or hear. So, hearing voices, seeing things, these would all be examples of hallucinations. Most individuals with schizophrenia are going to report hearing voices. So, basically, these are going to be auditory hallucinations whereby the individual thinks that someone is talking to them, maybe even telling them to do things. And a lot of times, these hallucinations are going to be very unpleasant and they're going to make the person feel really bad about themselves or tell them to do dangerous or unpleasant things. Additionally, as I mentioned, some problems thinking and speaking often are symptomatic of an individual suffering from schizophrenia. So, disorganized speech, inability to communicate coherently, you definitely see that in sufferers of schizophrenia. You additionally have delusional beliefs. This is a little bit different from a hallucination. These are basically grandiose beliefs or paranoid beliefs that are not grounded in reality. So, a delusion is more so a belief that you have that's not grounded in reality versus a hallucination, which is a perceptual experience one has that's not grounded in reality. The linked video there, I definitely recommend you check it out. Imagine the experience of having voices in your head and just how hard that would make it for you to pay attention and to speak coherently. The idea that it's really hard to block out a voice when it's coming from your own head. So, trying to empathize with individuals with schizophrenia and understanding just how difficult it would be to deal with these very, very serious symptoms, I think is important to make sure that we're thinking empathetically about individuals with schizophrenia and make sure that we understand that it's a very, very serious and difficult condition to live with. Additionally, you see individuals with schizophrenia display odd or socially inappropriate emotions, being happy when they shouldn't be, or just behaving bizarrely, or a flattened affect. So, this is going to be when the individual does not really display any emotions whatsoever, just completely flattened, which again is typically going to be considered socially inappropriate to have no visible emotional output whatsoever, and additionally difficulty perceiving emotions in others. So overall some difficulty in displaying and understanding emotions. Inappropriate actions or behavior. Examples of these sorts of behaviors include repetitive rocking type behaviors, this catatonia that I mentioned before, sitting motionless and being unresponsive for long stretches of time. In terms of what might be causing these inappropriate behaviors, schizophrenia can cause a lot of different disturbances. For example, the presence of delusions and hallucinations are going to cause a lot of distraction for an individual. It's going to make it really difficult to focus. It's going to make it very hard to concentrate. So, overall, individuals with schizophrenia display a diverse range of symptoms that are likely all sort of going along with the hallucinations and the delusions that the person is experiencing that cause a significant amount of difficulty. So, in terms of diagnostic criteria for schizophrenia, again, you see the classic DSM setup, whereby there's a list of symptoms that one might experience falling into various categories. So, that first list of characteristics or symptoms of the following. This list includes your delusions, hallucinations, and disorganized speech. The second list is going to be more so focused on social or occupational distress or dysfunction. Additionally, you're going to have a diagnostic criteria related to the duration of the symptoms. Symptoms of schizophrenia need to be present for at least a month, and signs of disturbance at least 6 months out. So, this does tend to be a relatively persistent disorder. Additionally, the signs and symptoms of all of the above criteria should not be accounted for by any other disorder. So, if there's any other diagnostic criteria that helps explain the pattern of symptoms, the idea is that diagnosis would take precedence over a diagnosis of schizophrenia. Again, a short video linked there to sort of uh, understand a little bit more what individuals with schizophrenia might be experiencing. Basically, talking to a series of patients that are experiencing schizophrenia in very different sorts of ways. Again, I think it's important to understand that with this sort of diverse range of symptoms, the idea is two individuals similarly having a diagnosis of schizophrenia can present very, very differently, and understanding that schizophrenia is going to be something that might be different person to person, despite the fact that it's so associated with delusions and hallucinations. There are other ways that schizophrenia can manifest. Additionally, you see various subtypes for ways that schizophrenia can manifest. So, again, based on the fact that there's different patterns and collections of symptoms that can go together, they can sort of combine. Symptoms can combine in unique ways to create these different schizophrenia subtypes. So, for example, you might have your paranoid schizophrenic, and this is definitely going to be primarily the sufferer dealing with hallucinations and delusions. This is going to look quite different from someone who's having a more of a catatonic experience with schizophrenia. So, this is going to be that flattened affect, that extreme amount of withdrawal, that not engaging, not moving, not speaking. And so basically, with the list of symptoms that might theoretically lend themselves to schizophrenia, the idea is that different combinations of them might lead to a very, very different subtype of schizophrenia. So, again, I think it's important to keep in mind that not all individuals with schizophrenia are alike. You have these different kinds. And as such, there should be different targeted treatment for the different subtypes of schizophrenia. In terms of the prevalence of schizophrenia, nearly 1 in 100 people will develop schizophrenia. You do see the rate slightly more higher among men. So, obviously, this is not the most prevalent disorder. There are other disorders that are much more prevalent, like depression, but obviously, it is quite severe. You typically see the development of schizophrenia happening in adolescence or early adulthood. Basically, you would not be likely to see a case of schizophrenia develop in an individual who's into their 30s. This is typically going to be something where the first instances of symptoms will be in adolescence or early adulthood. Often development is going to be precipitated by a stressful life event. So, possibly the fact that a lot of the onset happens in adolescence and early adulthood is that there's going to be a lot of massive life changes that take place during these time periods. So, for whatever reason, you do tend to see the vast majority of development of schizophrenia happening to younger individuals. Additionally, the way schizophrenia can sort of play out over the course of one's lifetime, you might have a more acute or reactive schizophrenia that can sort of be understood to not be permanent. That is just a sort of a strong reaction to a stressful event. And some individuals, on the other hand, are going to experience more of a chronic issue with schizophrenia, where it really is going to be a lifetime diagnosis. So, acute or reactive development of schizophrenia, again, this is going to be when schizophrenia emerges when someone experiences a high amount of stress. And you do see that these more acute cases of schizophrenia are going to see some of those more classic symptoms like hallucinations, which might seem like it's much more serious, but it's actually these cases in which recovery and successful treatment are actually more likely. Your chronic development of schizophrenia, on the other hand, it's not going to seem quite so abrupt or serious because the development is going to be a bit more slow, and you're going to see more of those negative symptoms like your flattened affect and your social withdrawal. This is actually more of a bad sign, despite the fact that this might seem less severe than an individual who's suffering from hallucinations and delusions. The prognosis for those with this more chronic type of schizophrenia actually have a slightly less positive prognosis. Treatment is quite a bit harder, and the individual likely will continue to suffer from symptoms throughout the course of their lifetime. You do see some reliable brain differences in individuals with schizophrenia. Most famously, the neurotransmitter dopamine is found to exist in abnormal levels in individuals with schizophrenia. It's thought that dopamine potentially might have a role in the existence of paranoia and hallucinations. So, dopamine is a very interesting neurotransmitter. Again, it has to do with reward systems and experiences, but for whatever reason, it's also at play in schizophrenia. So often, treatment for schizophrenia is going to involve a medication that helps manage dopamine levels. Additionally, you see at a brain level poor coordination of neural firings in the frontal lobe that will be associated with diminished executive functioning, self control, long term judgment, and planning. So you see differences in terms of the electrical communication in the brain. You see various changes to the firing rate of the thalamus, which, if you recall, has to do with the experience of sensation and perception. So, the heightened activity of the thalamus actually indicates that likely at a brain biological level, the individual is perceiving those hallucinations, those voices, as very, very real because their entire sensing system is basically telling them that it's real. You additionally see some overall shrinkage of various brain areas, including the corpus callosum and the aforementioned thalamus. So you do definitely see brain differences play out in individuals with schizophrenia, indicating that there's a very strong biological basis for this disorder. Additionally, you see random fluid pockets throughout the brain, associated again with this general shrinking of brain areas and less brain matter. Schizophrenia, as with bipolar, has quite a bit of a genetic predisposition component. Based on twin studies, we understand that the likelihood of identical twins developing the disorder, you do see that there's a 6 in 10 chance of the other twin having schizophrenia if one does. So, this basically tells you that there is a great amount of a genetic predisposition to the development of schizophrenia. Basically, as with many disorders, you need to have both a genetic predisposition and you need to have a stressful factor to kick off the disorder. Given the strong genetic component of schizophrenia, a fair amount of that predisposition is going to be sort of built into your genetic makeup. Again, in terms of prevalence, we basically see that the closer someone is genetically, the more likelihood it is that they're going to have a shared risk of developing schizophrenia. So, as you can see, identical twins who share the most amount of genetic overlap have the highest rate of concurrent risk of developing schizophrenia. And as you go through family members that have less genetic similarity, you see that rate of shared risk fall quite dramatically. So, again, as with bipolar, schizophrenia is a disorder that has a very, very high amount of genetic vulnerability in terms of putting someone at risk for developing this disorder. It's not all heritability, though. Again, 80% indicates that it is greatly genetically determined, but there's that leftover 20% left to explain who else is going to get schizophrenia. So there's a lot of prenatal factors, things that individuals experience before they're born that can put them more at risk. So basically, any sort of negative prenatal and birth outcome, so being deprived of oxygen in the womb, a experience of having a virus or teratogen during pregnancy, other negative birth variables such as birth weight, the experience of undergoing stressful famine while you are in the womb. All of these risk factors present additional likelihood of increasing one's vulnerability to schizophrenia. Additionally, environmental factors, definitely the risk of schizophrenia is heightened if an individual experiences certain negative environments or circumstances throughout the lifetime. So, to be poor, so socioeconomic status definitely has something to do with it, poor or abusive family environments, and possible trauma in childhood. All of these risk factors will interact with someone's genetic predisposition and interact to make it more likely that someone will develop schizophrenia. So, again, given the really high genetic predisposition component, experiencing anything from this list is not necessarily going to cause you to develop schizophrenia if it isn't built into your genetics. But if an individual who does have the genetic predisposition experiences any of these factors, the likelihood of developing the disorder basically is much, much higher. Okay, that'll do it for bipolar and schizophrenia. I'll finish out this section on psych disorders with dissociative personality disorders and eating disorders.